I think that we're all familiar with antibodies, and they're very powerful tools that we use on a daily basis for the diagnosis and treatment of cancer. And the reason why they're so valuable is that they can bind to targets with really exquisite specificity. And in binding to extracellular targets in cancer cells, they can block signaling pathways, causing cells to stop growing and to die. They can also activate immune responses so that cancer cells can be killed by the immune system. So antibodies are widely used in oncology, hematology, and rheumatology, as well as infectious diseases. And antibodies have really become the cornerstone of treatments in hematology oncology. For example, an anti-CD20 antibody, rituximab, has been used for the last 25 years and has really transformed the treatment of B-cell lymphomas. Bevacizumab, which is an antibody against the VEGF, which is the vascular endothelial growth factor, is very useful in treating colon cancer, ovarian cancer, and cervical cancer. Lastly, as you all know, antibodies against immune checkpoints, which are regulators of the immune response, have become very, very important in the treatment of cancer within the last 10 years and are used in treating multiple cancers. Almost every day we hear about another new indication for using immune checkpoint inhibitors in treating cancers. And it's, again, transformed the outcomes in cancer treatment. However, what I will do today is talk to you about not naked antibodies, but two modifications that we can make to antibodies which make them very useful and very powerful in the treatment of cancers. The first I will talk to you about is antibody-drug conjugates. And these are a class of cancer therapies where antibodies are linked to drugs or even radioactive molecules. And in that, using the specificity of the antibodies can deliver these drugs or radiation molecules to the cancer cells in a very specific way. So as you can see, it's been really looked at as really a smart bomb, okay, where the antibody directs the payload or the drug to a cancer cell specifically. So as you see in this picture, there's an antibody that's very specific. It's linked to a drug by a linker, and this drug then is delivered to the cancer cell. So in this picture, you will see a schematic of how it's thought to work. So on the left-hand side, what you'll see is that the ADC is delivered to a cancer cell in a very antigen-specific way, and it binds to the cancer cell, the surface of the cancer cell, is internalized into the cancer cell. The chemotherapy or the drug that's delivered by this antibody-drug conjugate is released in the cancer cell and kills the cancer cell in a specific way. And then, depending on whether you've designed a drug that's very permeable, what you will see then is that these drugs that have killed the cancer cell then can permeate out of the cancer cell and kill the cancer cells around this original cancer cell, mediating what we call a bystander effect. So now this is a very good concept, but does it really work? And the fact that I'm talking about it today means that it probably does. Now this is an example of one of the prototypes of the antibody-drug conjugate in terms of efficacy. This is a drug called brentuximab vedotin, which is a anti-CD30 antibody that's linked to a chemotherapy. About 15 years ago, the initial trials were done looking at the efficacy of this drug. And you can see in this waterfall plot that it's very efficacious. What a waterfall plot is that we see in many bars, each representing one patient. And if you go up from 0, it means you're not responding to the treatment. If you go down from 0, it means you're responding. And the deeper the bar, the descending, the better the patient is responding. So you can see pictorially that out of these 98 patients who were treated with brentuximab vedotin, who had refractory relapsed Hodgkin's disease, that almost every one patient responded, meaning that the tumors all got smaller. And this is really unheard of in a setting where these patients have all been treated with conventional treatments, had relapse, or become resistant to these conventional treatments. And this efficacy is actually mediated at the cost of very little side effects. You see some diarrhea, and you see some numbness and tingling due to peripheral neuropathy in these patients. Otherwise, this is a very tolerable treatment. So this drug works very well in patients after inducing responses, but does it improve cures? Does it improve long-term outcomes? The answer is yes. In this clinical trial, patients who had relapsed after initial treatment for Hodgkin's disease are consolidated with autologous peripheral stem cell transplants. In relapsed Hodgkin's disease, patients have to undergo transplant to be cured. However, some patients still relapse after the transplant. So in this study, patients who had undergone a transplant, and those patients who had high risk for relapse, even after the transplant, in terms of patients who never respond to the initial treatment, patients who relapse within 12 months of the initial treatment, and patients who had extranodal disease, were assigned to either placebo or brentuximab maintenance for about 6 months. So you can see in this picture that patients who received the brentuximab were cured at a much higher rate than patients who received placebo. And that this effect you can see even up out to about 7 years after the transplant was done. You can also add brentuximab to initial chemotherapy in Hodgkin's disease. In this study, patients who were initially diagnosed with Hodgkin's disease were randomized to either chemotherapy, standard chemotherapy alone, or chemotherapy plus brentuximab. And you can see in this graph that patients who were treated with brentuximab plus chemotherapy had a 30% decrease in the risk of relapse after initial treatment. So again, these drugs are making a big difference in curing more patients. So as it turns out, that the design of these drugs are not so simple. It's not so simple as just linking a drug to an antibody. There are actually many variables that affect how effective these drugs are. So these are some of the attributes that we look for in an antibody-drug conjugate. So first of all, you can select for better antibodies that bind the cancer cell more specifically, and you can select antibodies that don't elicit immune responses from the host so that they're not eliminated by the immune system. Number two, you can improve the payload. You can improve the bomb part of the smart bomb, which is the chemotherapy part. You can link better chemotherapies to which the cancer cell is less likely to be resistant. You can load more bombs into your bomb so that it's more potent once it's delivered. So the way that's expressed is the drug to antibody ratio, where you want to have more drug per antibody molecule. You also, as I pointed out before, want to choose drugs that have high membrane permeability to allow these drugs to kill by a bystander effect. And lastly, you want to make better linkers. You want to make a linker that's more stable so that it doesn't release the bomb in the circulation and kill healthy cells, but you want to make linkers that will be only cleaved once it gets into the cancer cell so that it will only kill the cancer cell. So, is that possible? Well, in fact, it is. This is an example of a second-generation drug antibody conjugate called trastuzumab deruxtecan. Now, it's composed of 3 components. It's composed of an anti-HER2 antibody. HER2 molecule is overexpressed in a number of cancers such as breast cancer, colon cancer, and gastric cancer. And the payload it's delivering is a topoisomerase 1 inhibitor, which is very effective in killing cancer cells. And the linker that it's used is very specific, it's very stable in the circulation, and it's broken down only in the cancer cell. So it really ticks all the boxes in terms of a good bomb or payload, a high potency payload. It has a high drug to antibody ratio of 8. to give you a perspective, the usual drug-antibody ratio in an earlier generation ADC is only about 3 to 4. So you've doubled that. The payload has a short systemic half-life so that it has less side effects when it's given to the patient. It has a stable linker, and it's tumor selective in terms of the linker, and it's membrane permeable. So in theory, this should be a much better drug than what we had before. So now we can see whether that's really true. Next, please. So this is some data that was just presented about 4 months ago at the European Society of Medical Oncology meetings. And it's looking at the ability of trastuzumab deruxtecan to control metastatic breast cancer as compared to TDM1. TDM1 is a first-generation anti-ADC, which is also directed toward HER2. You can already see in this graph that, in fact, it's much more effective. The response rates for trastuzumab deruxtecan is about 80% versus 35% in TDM1, so that the response rates are much, much higher. You can see from the waterfall plots that you see more responses and deeper responses in patients who've received trastuzumab deruxtecan. Now, does this improved response rate convert to improved control of disease? Again, the answer is yes. This is what you'll see in this graph is a graph of the progression-free survival, or the period of time that the patient's tumor is controlled after being treated with trastuzumab deruxtecan versus TDM1. In the upper blue line, you'll see that the survival, the progression-free survival in terms of the period that the disease is controlled is much, much longer than the bottom gray line. In fact, we see that the improvement is about 72%. So that this drug is 72% better than the standard treatment that we have right now. Now, to give you perspective, the usual benchmark that we use in oncology is that if a new drug is 30% better than the drug that we're using right now, then we think it's worth using the new drug. In this case, this new drug is 72% better than what we're using right now. Again, this is a stunning result. And hopefully that it will be usable in more patients, giving patients much longer survival times. So because of these characteristics, ADCs are being developed at a very fast rate. A lot of them are in routine clinical use. I want to highlight the first molecule on the list, which is polatuzumab vedotin, which is an anti-CD20 antibody that's joined to a drug. We've already been using this for a number of years in treating relapsed refractory diffuse large B-cell lymphomas. Just about a month ago, some very exciting data was presented at the American Society of Hematology meetings in Atlanta. And this showed that if you combine polatuzumab with standard chemotherapy in patients with newly diagnosed diffuse large B-cell lymphomas, you can actually cure about 30% more of these patients than just with chemotherapy. I also want to highlight the last drug on the list, which is dapipotamab deruxtecan, or DS1062. It's a second-generation anti-TROP2 plus a topoisomerase inhibitor. This is a very exciting molecule because in the phase 1 trials, the drug produced very high levels of activity in very resistant lung cancer patients. Right now, we're doing a trial at our site, as well as other sites in Singapore, testing this drug versus chemotherapy in patients with lung cancer. We're very excited about the prospect that we'll have new treatments for these patients who need more treatment modalities. In the last few minutes, I will talk to you about another platform that's very exciting, and this is the Tcell engaging bispecific antibody. And these are antibodies which are actually linked together to form an immunologic, what we call an immunologic synapse, to induce immune responses against the tumor. So essentially, you have, in this case, an anti-CD19 antibody, which binds specifically to the tumor, and an anti-CD3 antibody that's linked together. When they bind the cancer cell and the T cell, they bring them together and elicit antigen-specific immune responses against the tumor. We already have drugs that work in this way, and we'll show you an example now. Next, please. Next. And this is a representation of some results with blinatumomab, which is the first bispecific T-cell engager that came into use. And blinatumomab is an anti-CD19, anti-CD3 antibody, which produces immune responses against the tumor, and it's indicated for use in acute lymphoblastic leukemia. And you'll see in this graph that patients were treated with blinatumomab after they had relapsed after initial therapy did much better than the patients who were treated with chemotherapy, both in terms of duration and control, and both in terms of overall survival rates. Next, please. There are other T-cell engager bispecific antibodies that are in development that are quite exciting. This is glofitamab, which is the anti-CD20, anti-CD3 antibody, which is very active in treating a number of B-cell tumors. This is data showing about 300 patients who were treated with these antibodies, and these patients were all very highly refractory to conventional treatments, including patients who actually relapsed after CAR T-cell therapy, which is a new, very advanced immunotherapy, which is we're using in Singapore. After this treatment, patients can still respond to these bispecific antibodies. Again, you'll see this waterfall plot where most patients who were treated did respond to this treatment. Next, please. This is an example of a patient who was treated on this study. This is a patient on the left side. You'll see that the patient was diagnosed with lymphoma, and all this black in the abdomen was active lymphoma. Now, the next picture is a picture of the patient after 2 rounds of chemotherapy, both R-CHOP and ICE, which are commonly used chemotherapies used in treating these lymphomas. You'll see that there's still residual disease after chemotherapy. And that's a very bad sign for patients with diffuse large B-cell lymphomas, because in this case, they'll do very poorly and they'll progress and then die of their disease in a short time. This patient was treated with glofitamab, and you'll see at the baseline, the patient still had disease, but the 4th picture, you'll see that that disease had disappeared after treatment. And even 2 years after completing the treatment, the patient still had no evidence of disease in their body. Again, this illustrates another point about immunotherapy, which is that immunotherapy, once we can induce a potent immune response in the patient against the tumor, the survival and the control of tumor can be very long because the immune system continues to control tumor inside a patient. And this is very exciting for treatment of these diseases. Next, please. So there are a number of bispecific antibodies that are in routine clinical use and late-stage trials. Blinatumomab, we talked about, and amivantamab, which is an anti-EGFR, anti-MET antibody, is in routine clinical use now. And the number of them are in development. I'll highlight the last one, the Regeneron compound, which is the anti-CD20, anti-CD3. We have a trial going on at our site and other sites in Singapore with this very exciting compound, which seems to be also very active in the treatment of lymphomas. So I hope I've illustrated to you how we can use antibodies to improve treatment outcomes in cancer. We're learning new things every day about these antibodies and modifying them to make the outcomes better. So I want to take this opportunity to thank you for your attention.